guys, it's Dr. Greer. Dr. Gallus will be hopping on in a minute. We're doing another episode of Carpools and Cannulas and talking about more breast stuff today. So once she hops on, we'll get going. I hope you guys are having a delightful evening on this fine, cold, snowy Monday. All right, there's Dr. Gallus. You guys can leave questions in the comments as we go, or if you have ideas for other topics.
Cold. Hey, I'm good. How are you?
How are you? I'm good. It's really cold, and we got like 3 inches of snow yesterday. So.
It's cold here, but like, you know,
like 50.
Sorry, but we think it's cold as soon as the sun.
It's okay, because you came over to live there.
People are smuggling eggs across the border. Crazy. Yeah.
For real?
So dumb. I
know they're expensive here, but maybe
I know. Eggs are so expensive, and so it's become this thing. And then I'm like, do people really eat that many eggs? Or not? It's sort of like toilet paper hoarding at this point. I don't know.
I mean, I think at my hungriest, I ate a dozen
eggs.
Yeah, I mean, I've been doing intermittent fasting, and I hadn't eaten for like 18 hours, and I made like 6, and I ate them, and I was still hungry.
Oh, okay. Like 12 hard-boiled eggs would be awful.
Is it? I don't know. There's this recipe for hard-boiled egg pudding, which sounds gross, but it's amazing, and it uses allulose sweetener, coconut milk, and cocoa powder, and cinnamon. And you blend it like in a Vitamix, and then you have to let it sit overnight. And the egg smell totally goes away. It's amazing. It's like chocolate mousse. So you could definitely eat a dozen.
All right. I'll take your word on it.
They're on that. Yeah, I mean, I think people undereat eggs when they're like, I ate eggs for breakfast and I'm still hungry. And I'm like, yeah, but you have like 2. You got to have like 6. Hi, Amanda. You're watching tonight. You were on last time, weren't you? Didn't you watch last time we did a Carpools and Cannulas too? I feel like you were on here. So thanks for watching again.
So we're going to bust some boob.
Yeah.
Was that the?
Yes, because we both love breast surgery, and there's like a lot of just weird things. You know what else? What other myths we should talk about too? Although it's not breast surgery related. Pumping and dumping, and when you actually need to.
I think.
Oh, there's my other Amanda. Hi.
Amandas are watching. All right.
Well, I know. We're in good company. Cool. All right. Let's see. What question do you get the most that drives you nuts?
It's pretty common.
Or not drives you nuts,
I just had one today that comes up, and it's like, my implants have been in for a while. They don't bother me. I'm happy with them. What do I need to do? Nothing.
Right. Yeah. Nothing. As long as they're intact, if they're silicone. If they're saline, it's not a big deal if they rupture, but if they're silicone, they do need to be.
So people get worked up about the 10-year mark, but it's when 2 of the major companies' warranty expire. However, so if you have an implant, but just for an implant problem like capsular contracture, they now will warranty them for rupture for the lifetime of the implant, if I'm not mistaken, for all of them.
I have not checked recently, but I remember you telling me this.
So, but for rupture, you definitely want to remove it. Saline rupture, you're right. You don't have to. I took care of a friend of mine who is a physician who had her implant ruptured for 4 years, saline on one side, just because she was busy. She got pregnant. She had another kid. So busy because it was her 4th kid. And then she's like, okay, I need you to take it out and put a new one in. No, because
were they really uneven the whole time?
Put them in when she was much younger and she was bigger and had breast tissue now, so it wasn't that big of a difference. But it seems 4 years is a long time to walk around with a deflated implant. Just FYI.
Yeah, I mean, if they were both deflated, I'd offer for people to deflate the other one. But I mean, ideally, you do want to remove them, which you can do under local. But yeah, silicone, the problem is over time, it can cause inflammation and you get granulomas and scar tissue and
somebody
things like
come
that.
in who had her implants
in the long
term. In the 80s, and they were clearly past their prime. So that makes it a more difficult surgery because they're calcified and ruptured, and now the pocket is distorted because the implant has ruptured, and then the capsule like walls it off, and then it ruptures, and then it walls it off. So now you have this like weird blob in there that's a little bit of a hot mess.
I've seen really extreme cases. Sorry, we're going to get some cat tail in here, I think. But where one patient had had implants removed that were ruptured, and then there was still enough like silicone inflammation in the tissue that it wouldn't heal. And then I went and excised more, and there was more scar tissue and bits, and it did not want to heal just because the silicone had kind of seeped into the tissue. Although those are also the older generation implants from the 80s and 90s, the silicone in them was much more liquidy, like honey. The newer cohesive gel is very solid, although I can't tell you what it's going to look like in 25 years.
Right, I agree. But yes, the older implants, unfortunately, those are the ones that if they've been in for a long time, they were honey to start with, or motor oil, and they just sort of bleed everywhere. That's where they get one of the silicone bleeding problems, where it's just going into the tissue and your body starts to wall it off or has an inflammatory. That being said, if you're 10 years out from having your augmentation and you don't have any problems, and if you're of an age to get a mammogram and mammogram's fine, and or you've had an ultrasound or an MRI to check them out, just keep on tracking, don't mess with them.
Then you're fine. And that's the nice thing too. Ultrasound is so widely available now. It used to be a $40,000 machine, so we didn't have it. We'd order you one, but now it like hooks to your cell phone. I have a little probe. I was able to bring it home and ultrasound my nanny last time she was pregnant, but now we can just ultrasound the patients in the office and check for rupture. So that's much more simple.
Okay.
Yep. All right. So that's a common one. I get a lot of questions about like, do I need to wear a bra all the time, or will my breast sag? That one is interesting because people talk about like ligaments in the breast. It's soft tissue, guys. It stretches over time, and it will stretch over time, especially if you gain weight or you're pregnant. That said, I do recommend, and I don't know if you do this, I do recommend to all my augmentation patients to at least sleep in a loose sports bra, because yeah, really, if they can. I mean, just that added weight, you're adding a good 300, 400 grams to the breast.
I feel like
that's
putting weight on it. It's a smart move. When I had my augmentation, I slept with a bra for probably a couple years just because I was afraid of them moving. But, and they weren't, not that large. But I've also had people tell me the whole point of getting an augmentation is to not have to wear a bra. Which you don't.
But I mean, it's not like there've been any randomized controlled trials where somebody supports one side, not the other.
Yeah, and there's so many factors, right? It depends on the quality of your skin, right? So if you have stretch marks going into it, I would say probably lean towards the bra. And if you have large implants, large heavy implants, if you have subglandular implants, it's going to stretch everything out faster. And and if your skin is sun damaged, I mean, there's not too many topless people. If you smoke, so all of those things are going to make your breast tissue drop faster anyway. So maybe support it with a bra. So you tell them. I went to a conference one time where some ancient old man got up there and was talking about his post-op protocol for augmentation, and said that he told his patients they had to sleep on their back. And I was like, okay, for the rest of their life. And I was like, no.
That's not going to happen. Yeah. I mean, I tell them, like, ideally, at least, like, a tank top with a shelf bra. Like, support it a little bit. I'm not saying, like, full-on bra. Or, like, a loose sports bra. Yeah, and then if you're doing anything high impact,
and I think if you run a lot, all those things have impact over time. You definitely should wear some support. I don't know why you would go running or do high impact without a bra.
Right. Can you get a breast lift without removing implants? So good question. It's going to be very patient dependent. How long have the implants been in? Are they in the right place?
I would say if they're under the muscle,
if they're
probably.
Then yeah. Yeah, or if they're like 2-year-old implants and the breast tissue is just dropping off them because you didn't do a lift at that time,
I
then
would
yeah,
say,
absolutely you can do a lift.
I just saw a brand new breast augmentation patient today, and that's one of my, I talk about all the different decisions. One of them is whether you go under the muscle or subglandular. And one of my arguments for going under the muscle is that the muscle supports the implant over time. So if your breast tissue does drop with age, gravity, whatever, then it's much easier to do that lift over the implant. Yeah. So absolutely.
Oh yeah, 2 years out, those are pretty new implants.
And if it's
you don't
not
need to
a
swap
big
those out. Yeah, you can definitely do a
mastopexy,
lift.
a lot of times I'll do it under local or sedation. You don't need to go under general anesthesia. Still 2 weeks of raising your heart rate and blood pressure afterwards. But yeah, the recovery is much faster.
Yeah, so definitely doable. Let's see. Oh, let's talk about breastfeeding and breast surgery. I have people wait 6 months after they stop, but be aware, people, your breasts make milk for a long time. Like I've seen milk in there a year out.
An augmentation mastopexy on someone who was in the healthcare profession, as you all know, are usually the worst. We're the worst patients. Anyway, so she had sworn up and down that she had stopped breastfeeding like a year ahead. And I went in there, and as I was making an incision in the breast tissue, I was rearranging stuff. And my anesthesiologist at the time had leaned over, was talking to me, and I happened to hit a milk duct, and it sprayed out. And luckily he was wearing eyeglasses, and it hit him right in the eyeglass, and he just stopped what he was doing. And I was like, hey, I'm really sorry. She's not even supposed to be breastfeeding, so I don't know what this is all about.
I mean, as bodily fluids go,
he was.
Not a bad
this was at the baby, so he was traditionally a pediatric anesthesiologist, and he's like, that's why I don't operate or don't work with adults. I was like, you need to calm down. He had to step out. He was so appalled. But yeah, so you don't want to operate if you are breastfeeding or recently breastfeeding for lots of reasons. If you're putting an implant in, there's a foreign body, so breast milk isn't sterile, so you don't want to create potential for an infection, right?
Right. Also can stop your incisions from healing. You can get a breast milk fistula where the milk is coming out.
And then also, if it's not an implant related case, if it's like a breast lift or breast reduction, I tell people, well, if you're still breastfeeding, your breasts are changing shape. So now we're trying to get a moving target. So maybe wait for that shape to settle out. Like once you're done breastfeeding, your breast might shrink down a little bit more, and I don't want to take off tissue that's not even going to be there in 6 months. So that's another reason. There is one operation I'll do if they're just like a month done, not actively breastfeeding, but recently completed, and that's just implant removal if they're just taking.
So, yeah, because you're really not coming across any of the milk
exactly. You're not trying to change, and that's just straight removal. We're not trying to change the shape. We're not doing a lift. We're not doing fat grafting. They just want to get them out. That's totally fine. But yeah,
usually 6 months. It takes a while for the breast milk to dry up, so I usually tell people 6 months. So I'll see them for a consultation about 3 months after they've stopped, and then we're booking out 3 months. So that's how long, which I've tried to be really conscious and ask anyone with a kid like 4 and under if they've been breastfeeding recently.
You just don't want to, like I said, you're trying to get the shape and the size right, and that's still changing. Might not change you on the day-to-day, but over months it is. And then also the risk of having contamination or a fistula is no fun.
Right. So peripherally related question, will you do toxin or filler injections on patients who are breastfeeding? Because that comes up a lot.
No, I won't. But I know we've informally pulled female plastic surgeons, and we've all done it.
And it varies. Yeah, I will. I got toxin and filler injection. Well, I got them while I was pregnant because I do it myself. But I will definitely do toxin and filler injections on patients who are breastfeeding.
There's nothing that shows it. Like it shouldn't go anywhere. There's no expression.
Right. It's not going to go in the breast milk. Now, pregnancy, it's just such a litigation issue. Oh, side lipo with breast reduction. I think we both do side lipo with breast reduction. Yeah. Yeah, that's part of my standard reduction. Some people really don't have any fat there, but if you do, I like it.
It's a nice touch. So that's breastfeeding. We covered the bra.
We got to talk pumping and dumping. And I know this isn't a surgical topic. There's a whole Facebook group of physician women who breastfeed, which I got added to when I had my third kid. Because I've breastfed 3 kids and I pumped exclusively for the third one. And it's such a hot topic on there because medicine is not really up to speed on what you need to pump and dump for, which is almost nothing. Like they will tell you narcotics. Basically, yeah, like if you have an MRI with a gadolinium, if you have a CT scan, they'll tell you to pump and dump. And there are very few medications where you actually cannot breastfeed afterward. And alcohol, too, is another big one that comes up. So if you're taking narcotics, basically if you're awake enough to like hold the baby, you're okay. You can breastfeed. And then for alcohol, what I learned, thank you to the Dr. Milk group, is your breast milk alcohol content is equal to your blood alcohol content. So if you're totally slosh and your blood alcohol content's 0.08, that's the breast milk content. That's like equivalent to orange juice.
Okay, yeah. So that it's low. It's like kombucha.
That's what the baby's getting. Yeah. Yeah, exactly. It's like a fermented kombucha. So basically, if I think the rule of thumb was if you can find the baby, you can feed the baby. Like if you're sober enough to safely hold the baby without
interesting. So it shouldn't have been that hard to look at, right? You just take breast milk from somebody who's pumping and dumping or doing whatever and test it. Interesting. Yeah. Good to know.
Yep. Yeah. So it's exceedingly low unless you were like passed out drunk. But the other thing you could also do is pump that milk and then dilute it with milk that has no alcohol in it. So people throw out a lot of breast milk unnecessarily, which if you've ever breastfed, that's
right. Yeah. It's too hard.
Yeah. So that was my little soapbox.
No, that's good. Let's see. What other, here's another, it's not a breast myth, but I think it's something that comes up. That little, as Ashley and Ralphie calls it, chicken nugget, that little tissue that's in between your armpit and the breast, that little axillary fat pad is either a little fat pad, but sometimes it can also be accessory breast tissue. And I think it does really well with liposuction, but sometimes the first thing I do, I look, if somebody looks like they have accessory breast tissue, which is breast tissue up there, is if you look along like what would be a milk line, you can often see an accessory nipple somewhere along there, right? Mm-hmm. So you can see, hey, also you have this little mole here that is supposed to be a nipple. Yeah. Or underneath their breast, like on the chest wall.
Yeah. I remember learning about that in medical school, and I was doing a master's in biomedical ethics, and one of my classmates was like, oh, I have one of those.
Yeah. So like I said, I usually treat that with liposuction as well. Do you?
I lipo this area on almost all my reductions because everyone's just got that little bit of armpit fluff. But if it's like, sometimes you'll see like a big mass of tissue and extra skin, and then I excise. Right. Because you got to get that extra skin off too.
Not to do that because I try to hide incision in the arm. But you don't want to have somebody self-conscious about an incision up in their axilla or not be able to wear tank tops or something. But yes, I have had to excise it a couple times because they legitimately just have like a second breast there, or
yeah, exactly. And in that case, like they're probably way more comfortable with the scar than they were wearing tank tops with that big mass.
And then actually this came up today in clinic. Somebody asked me about fat transfer to the shoulder grooming for breast reduction, which Dr. Ralphie had done a study on it a long time ago. But I was doing doing liposuction on this patient anyway, and she has shoulder grooving from just large breasts from augmentation, and she likes the size of her breasts. Mm-hmm. But we talked about putting a little bit of fat in there to try and see if you can smooth that out. It's just, if you're already there and you have fat, kind of why not, right?
Right. Otherwise, about sculptor maybe.
But it's a little expensive.
Because it's not area. Yeah. Interesting. Although I feel like, if they still have large breasts or large implants,
we talked about that.
Keep
but if you're doing liposuction with your breast reduction, you could just throw a little in there.
Yeah.
Yeah. I feel like she presented at a women's conference. So Dr. Sneed is joining us. So yeah, that's my other things you haven't considered with your breast tissue. What about nipples or inverted nipples or any of that? Do you do a lot of that surgery?
I do some. The interesting thing is I think like a 17, 16-year-old patient come in once for inverted nipples, and I really didn't feel comfortable doing something that was normal anatomy and that would prevent function later. Like, I know she didn't want to breastfeed and didn't plan on it, but so when you have inverted nipples, guys, it's because the milk ducts are shortened, and the correction, you cut those ducts so it can pop out. Like, imagine a little tuft in upholstery. But it was like totally cosmetic and would create a loss of function instead of a gain of function. And she really didn't want to try any of the non-surgical options. Like, they make these it's like a suction cup with a syringe to stretch the duct, and she didn't want to try that. She didn't want to try piercing.
Yeah, I mean, piercing seems like an easy way to work around that. What teenagers do.
Yeah. Yeah, so I've done a couple. I mean, often when I see them and they're really bad, it's because there's excess skin compared to breast volume too. So when you correct that tissue envelope to volume ratio, either by adding an implant or doing a lift, then it seems like the inversion gets better because the underlying tissue is better supported. I just augmentation
last week where she asked about her. I was like, I don't like messing with the nipple at the same time I'm doing an augmentation because that is not as clean and I don't want to contaminate anything. So we can always do it later. And then it everted with the augmentation. So problem solved.
Yeah. Oh, so other fun fact about nipples and reductions or lifts, I try to remember to tell my patients, like, if you have a horizontal bar pierced in your nipple, it's going to rotate 90 degrees or somewhere less than that because the nipple rotates up into its new position.
A little tip to let people know.
So, yeah, like, by the way, your nipple piercing is going to be 90 degrees from where it is.
Yeah,
no one's cared. They're like, yeah, whatever.
Yeah, no, I've had somebody ask me that before because they had like a mole on their areola, and then they're like, what happened here? And I was like, well, it all rotates. The mole's now here. But it's funny because I do think that the average patient doesn't think about what we're doing to get the nipple in its new position. And a common myth is that we're just taking it off and putting it back on, which you almost never do.
Yes, and we almost never do that. Like, that's just very, very large breast reductions. Well, and it's confusing to like try to imagine that three-dimensional thing. If you go on my TikTok, I have like a time lapse. I did a Play-Doh breast reduction a couple of years ago so that I could like show things rotating and what came out. Yeah,
I mean, I've had anesthesiologists go, I wasn't quite sure how you're going to put that together. And I'm like, really? Are you new? I knew exactly what the plan was. So your nipple and areolar complex stay attached to your breast tissue, and that bit of breast tissue is on what we call pedicle, and that rotates in some fashion to the new position. So it's crazy because it totally makes sense to us, but if only because we've done it 100 times, right? So
and even as a resident, I was like, wait, where does that tissue come out? And this rotates up. Yeah. But then you like figure it all out and you can imagine it, and it's part of mixed plastic surgery.
You can't unlearn that once you figure it out. So yes, I think that's interesting. Yeah. I'm surprised I haven't had anybody, because I feel like everyone in Southern California is pierced. So pierced or tattooed. Hasn't come up. Good to know. Okay.
What other fun breast facts do we have? Oh, are you ever too old to get a breast reduction? I get the question a lot. I'll have people come in and be like, am I too old for this? Woman, if you are alive and breathing and healthy, then
no. On people in their 50s and 60s. So you want to
like go for it. If your general health is good.
Absolutely. Yep. Yeah, I mean, some people just put stuff off. Now, the breast reductions, what I always tell my young patients is that you might need the surgery down the road if your breasts change with pregnancies or, you know, age and weight and stuff.
Mm-hmm.
But my 50 and up patients that have it done are like, oh, I should have done this 20 or 30 years ago. So
yeah. Oh, that is always the biggest complaint. So that they excited. And those patients too, I find, have had enough life experience, whether that's like joint replacement or having kids, that they're like, oh, that was nothing. I took Tylenol. It does hurt. It's just, I think they've got other life experiences where it's just not as big a deal.
Yes, exactly. I had an elderly lady who I believe was 70 or more, who I did a breast reduction on. She did great. And she's like, I'm just so grateful that when I bend over to brush my teeth, my boobs aren't in the sink. And I was like, yep. Good. Fun.
Yes,
fun
ma'am.
facts. So
that reminds me, one of the best consultations we ever had at the VA when I was in residency was a request for a scrotal pexy because his scrotum like hit the water in the toilet bowl when he sat down to pee. He wasn't concerned with the fact that he had to sit down. I think there was a buried penis issue too, which that is a medical condition, guys, by the way, where it gets kind of tucked in, doesn't pop out, and then it gets irritated and there's scar tissue around it. One of our urologists in our surgery center was actually doing surgery for it this week, and I made the mistake of peeking in and going, oh.
Urologists we need them.
Yeah, she's like, first step, I deglove the whole shaft. I'm like,
I used to help with those, actually, because some needed full thickness skin graft. So
yeah, I think she just closed with scrotal skin, and it turned out great. But it's funny, stuff that makes me squirm. Like, I will just peel down your forehead to do a brow. I mean, I don't do that technique anymore, but it bothers me not at all. But degloving things bothers me.
All right.
Okay, on that.
All right. Well, I will see you next week, right?
I know. I'm so excited.
Wednesday night.
Are you coming in Thursday?
Yeah. I'll text you.
Okay.
Do you have dinner plans? I have options every evening.
I don't. I haven't made any because I know there was the big WPS dinner on Thursday, but I have my boyfriend and I didn't want to expose him to 100 other women and torture him. So there's but we'll hang out. I mean, I'll drag him to dinner with people at some point. I just figured not the whole crowd.
I'm going to a smaller rep sponsored thing, but I will let you know. Okay.
Yeah. I mean, you definitely can meet him because you're both Navy veterans.
Excellent. Yeah. All right. Well, it was good to
well, I will
see you.
Fantastic.
Bye.
Thanks for joining us, everyone. Have a great night.